Hello, my name is Shabir Hasham, and I'm the Global Program Lead for Puldisa, also known as Idebenone, at Santhera Pharmaceuticals. I'd like to begin by thanking the organizers of this conference for the opportunity to share with you the results of a recent interim analysis we did on our phase 3 Sideros study. Some of you may be aware that the interim analysis unfortunately showed that there was no benefit for the combination of Idebenone and steroids compared to placebo in slowing the rate of respiratory function loss. The objectives of this presentation are to share with you the background and rationale for why we decided to conduct the interim analysis, to share with you the results of the interim analysis and also some preliminary insights from subgroup analyses, and importantly, to discuss the implications for Santhera's decision to stop the Idebenone clinical development program on the availability of Idebenone via early access programs and compassionate use. In 2015, Santhera published the results of the phase 3 Delos study. This study showed that Idebenone slowed the rate of respiratory function loss when measured in peak expiratory flow % predicted and met its primary endpoint in being statistically significant from baseline to 1 year. We also showed that treatment with Idebenone reduced the risk of bronchopulmonary adverse events, such as airways infections, the need for systemic antibiotics, and the risk for hospitalization due to respiratory complications. In parallel, data from the Synergy Natural History study showed that taking steroids delayed the onset of abnormal respiratory function, defined as being less than 80% predicted. But once below 80% predicted, the rate of decline was similar to non-steroid users. This observation has also been replicated in several natural history studies. Therefore, both data from natural history and the outcomes from the Delos study support further investigation of whether Idebenone could help to slow the rate of respiratory function decline in a steroid-using population in Duchenne. This was then the basis of the study design for the phase 3 Sideros study. As you see here, the Sideros study is a large randomized placebo-controlled study with one-to-one randomization to Idebenone or placebo. A total of 256 study participants were randomized. Key eligibility criteria were age 10 years or older, chronic use or stable use of steroids, and participants had to be in respiratory function decline, which was defined as having respiratory function of less than 80% predicted, as measured by forced vital capacity. The primary endpoint was the change in forced vital capacity, % predicted from baseline to week 78, assessed by hospital-based spirometry. There were also some key secondary endpoints listed here. Before I discuss the outcomes of the interim analysis, I wanted to say a few words on why interim analyses can be useful and why we decided to conduct one for the Sideros study. Interim analyses are a useful tool for making decisions about a clinical trial whilst they are running, without compromising the integrity of the study or its data. They can typically help to assess the need to modify sample size, adaptations to the study design, or, as was the case for Sideros, to help to decide if a study can be stopped early. The interim analysis was carefully designed, and a study protocol and analysis plan predefined strict criteria to help an independent Data and Safety Monitoring Board, the DSMB, who would be the only party to be unblinded to the data, to make a recommendation to Santhera once they had analyzed the data. The interim analysis statistical plan defined 3 strict criteria to help the DSMB to make that recommendation to either stop the study for compelling efficacy, to continue the study as originally planned, or to stop the study for futility, which means that the probability of the study being successful should it continue is low enough not to justify the continuation of the study. And for the purpose of this interim analysis, this was set at being less than 20% probability. In addition, other pre-planned analyses had shown that Sideros study was well powered to be able to detect a difference if one existed. In addition, we had data from 197 of the 256 randomized patients who had either completed the full study or a majority of the study, and therefore we had the sufficient amount of information to be able to conduct an interim analysis. What we also knew at the time was some insights from the Delos study. We knew the rate of respiratory function decline in the placebo arm and in the active arm. And here in the bold black line, you see the pooled analysis, and this is the combination of both the active and the placebo rates of decline. Natural history has indicated that once respiratory function is abnormal, the rate of respiratory function is similar to a steroid untreated population, which Delos was. And therefore, it was reasonable that if the blinded Sideros pooled analysis was similar to that of Delos, then we could infer that the study was behaving as anticipated from natural history. And we conducted this analysis, and indeed, the blinded pooled Sideros data was similar to that we had observed in Delos. This gave us further confidence to proceed with the interim analysis. In the next few slides, I want to show you the demographic data in the Sideros study as well as some of the primary outcomes of the interim analysis itself. You will see from this table that both the active arm and the placebo arm were well balanced in terms of age, estimated height, ambulatory status, age at loss of ambulation, and baseline respiratory function measures. They were also well balanced in terms of type of steroid used and the regimen of steroid used within the study. When the DSMB analyzed the data, they calculated that the probability of the study being successful if it continued was only 4%. They also concluded that there was no treatment benefit seen with idebenone in combination with steroids compared to placebo for the primary outcome measure of change from baseline to month 18 as measured as forced vital capacity % predicted. Therefore, the DSMB recommended to stop the study for futility. Once Santhera accepted this recommendation, we were able to unblind the data and conduct further analyses, including subgroup analyses. As this slide demonstrates, unfortunately, there were no subgroups that seemed to benefit from idebenone treatment. We looked at age above and below the median, region where the study was conducted, type of steroid and regimen of the steroid, and use of respiratory support such as ventilation or cough assist. As you can see here, all of the treatment differences were not in favor of idebenone, and therefore we cannot conclude that there is any subgroup that would benefit. Importantly, the adverse event profile of the Sideros study was consistent with experience we've had from other DMD studies with idebenone, and no new safety signals were observed. As Santhera has decided to discontinue the program, this unfortunately means that we are no longer able to provide idebenone as part of our early access programs or individual compassionate use requests. We have asked treating physicians to support patients in stopping treatment. If you have any questions or concerns, we would ask you to please contact your doctor for further advice. Finally, in summary, unfortunately, the interim analysis indicated that there was no benefit for treatment with idebenone in combination with steroids compared to placebo to slow the rate of respiratory function loss. Subgroup analyses did not indicate a benefit for any specific subpopulations. Based on this, Santhera has taken the decision to terminate the idebenone clinical development program, but is planning to fully analyze, publish, and share the study data so that the community can continue to learn about respiratory function decline and also continue to evolve study designs for this advanced stage of the condition. Santhera is deeply grateful to the study participants, families, patient advocacy, and clinical communities for their support and participation in the Sideros study, and we hope collectively to be able to still develop new therapies for DMD in the near future. With that, I'd like to thank you and wish you all well in these very difficult times. Thank you very much.